Hello guys and welcome to my channel. Today we are going to have a discussion on the topic of loading dose and maintenance dose of a drug. So we will be covering our topic under the following points. So let us take one heading at a time. Let us first understand what is a loading dose. Now loading dose basically refers to a single or a few quickly repeated doses that are given at the start of the treatment to attain the target concentration rapidly. Now one thing to note here is that if you look carefully, it does not only mean that we have to give a single dose, right? We can give a single dose as well as we can give also a few quickly repeated doses. The ultimate aim is to reach the target concentration of the drug very rapidly. Now what is the formula for loading dose? Loading dose is basically the target plasma concentration of the drug into the volume of distribution divided by the bioavailability. Now I have already discussed in detail about bioavailability. Please feel free to check out that video. The link will be given in the description box. So as we can see that loading dose, it is basically governed by the volume of distribution of a drug. Why do we need the loading dose? Now suppose we have got a drug with a very long half-life, right? So for a drug that has got a very long half-life, the time to reach the steady state will be very long. Why? Because it takes almost 4 to 5 half-lives for a drug to attain the steady state. So in case of emergency, we may not have this much of time for us to reach a steady state and the drug to start its action. So in that case, if we give a drug by the loading dose, then this thing promptly raises the concentration of the drug in plasma to the target concentration that we need. Right. Moving on, let us take an example to understand the concept of loading dose. Suppose we have to treat arrhythmia with the help of a drug lignocaine or lidocaine. Now this lidocaine, it's a class 1B antiarrhythmic drug. Now the T half of lidocaine is 1 to 2 hours. And suppose we have got a patient who has developed an arrhythmia after myocardial infarction. So now, as I've already told you, that the steady state would be reached in almost 4 to 5 half-lives, right? So for that patient, if we wait for 4 half-lives suppose, then we have to wait for almost 4 to 8 hours for that drug to reach its therapeutic concentration. That is, for lignocaine to reach the therapeutic concentration by infusion, we have to wait for 4 to 8 hours. Now a patient of arrhythmia may not have that much of time. We may lose the patient. Hence, we use a loading dose of lignocaine in the coronary care unit. And the purpose is so that we can quickly reach to the therapeutic concentration. Now let us have a look at a few drugs that are given by the loading dose. Now please understand that this is not an exhaustive list. Okay. So one of the drugs, that is amiodarone. Then we have lignocaine. Now amiodarone and lignocaine both are antiarrhythmic drugs. You have got the anti-malarial drug chloroquine, digoxin, which is given in case of cardiac failure, levetiracetam, which is an anti-epileptic drug, and clopidogrel, an antiplatelet drug, right? So these are the few drugs that are given by the loading dose. So what are the disadvantages of a loading dose? The first disadvantage is that a particularly sensitive individual may be exposed abruptly to a toxic concentration of a drug that may take a long time to decrease because of the long T half. Now see, suppose we have got a patient who is sensitive to a drug A, and this drug has a long T half. So now we have to, suppose we are giving this drug by a loading dose so that we can reach the target concentration very quickly. So most of the cases of loading dose, they are actually given by the parenteral route. So suppose we are giving by the IV route. So since we are giving this drug by IV route, the concentration of drug within the plasma will be very high, right? And so there will be two problems. The first problem is that the plasma concentration of the drug is very high. The second problem is that since the drug has a long T-half, now T-half is the time in which the drug reduces to 50% of its initial volume. That is, suppose a drug is having 100 mg, we are giving our drug, suppose in 100 mg, then the time taken by the drug to reach to 50 mg, 50% of its initial volume will be the T-half of a drug. So this T-half, since it is very high, so now the elimination of the drug will also be slower. The second disadvantage is that since the loading doses, they tend to be very large and they are often given parenterally, so now a large amount of drug is going to reach the plasma, so the chances of drug toxicity, it also increases. So we move on to what is the maintenance dose of a drug. Now maintenance dose is the one that is to be repeated at specified intervals after the attainment of the target concentration of the drug in plasma represented by CPSS to maintain the same by balancing elimination. So basically in a nutshell, what we are doing for maintenance dose is that we are actually balancing the rate of administration of a drug to the rate of elimination, so that a constant amount of drug is present in the plasma. So it is the formula for this is the target CPSS into clearance divided by the bioavailability. Now one important thing to note here is that maintenance dose is governed by basically the clearance of a drug. So the maintenance dose is governed by the clearance, whereas the loading dose, if you remember, it was governed by the volume of distribution. So now what is the significance of maintenance dose? In maintenance dose, as I've already told you, that the rate of drug administration is adjusted so that the rate of input equals the rate of loss. So the net result is that there is the maintenance of a steady state or the target concentration of a drug in the plasma. So to summarize our topic, loading dose basically refers to a single or a few quickly repeated doses given at the start of the treatment so that we can attain the target concentration very rapidly, and it depends upon the volume of distribution. Maintenance dose is the one that is repeated at specified intervals after the attainment of the target CPSS to maintain the same by balancing the elimination, and this is governed by the clearance of a drug. So that's all for today. If you like this video, then please give it a thumbs up, share it, and subscribe to my channel, and don't forget to press the bell icon so that you also know about the upcoming videos. Until next time.